Hello and welcome to the first ever IGCS Regional Connect meeting that brings together members of North America. I'm Alexander Olawaye, professor of OBGYN at the University of Pittsburgh and McGill Women Hospital of the UPMC. I am the current IGCS Regional Board member representing North America, and I have been serving in this voluntary capacity for the past 2 years, with one of my primary responsibilities being the senior advisor to the Early Career Network. It has been such a pleasure to do this, and we will be talking more about this in a few minutes. But I'd like to pause here and introduce my great friend, Professor Anis Sood from MD Anderson Cancer Center, who is going to be replacing me in this regional role after the Cape Town meeting.
Alex, I don't think you can be replaced.
No, I am very glad about the caliber of the person taking on the role of this position of mine. I think you are going to take it to greater heights. I'm confident of that. He's a good friend and someone that I have known for many years. We do an outstanding job. One housekeeping item is please write your name, specialty, and where you are joining from in the chat, if possible. And please do switch on your camera so that we can see you, because we like to. I'm handing over to Dr. Nadim Aburostum.
Thank you, Alex. I'm Nadim Aburostum. I'm very grateful to be here today, and thank you also to Rhonda Farrell, who's our vice president, to really put a lot of effort to see this initiative come to life. This is the IGCS team, and what a dedicated group of professionals that keep IGCS moving forward with all our work and projects and programs. They make being a volunteer leader at IGCS really amazing and honestly a very fun experience. So you can just see the team that we have. It's an incredible group, and I'm sure Alex would agree over the last several years working with them. So thank you, IGCS team. Some of them are with us today. Please say hi to them. And of course, many, many thanks to our CEO, Mary Aiken, who really leads this incredible organization and honestly makes everything such a true pleasure. So thank you, Mary.
Oh, thanks, Alex and Nadim. And thank you, everyone, for joining. I am Mary Aiken. I'm the CEO of the IGCS. I just finished my 10th year. That's hard to believe, but I want to welcome all of you to this new membership initiative called our Regional Connect. It's so exciting to be a part of this great initiative. Some of the objectives that we hope to accomplish by having these regional connects are really to bring the members of IGCS closer together and to strengthen our collaborations and, of course, knowledge sharing. We hope these meetings bring you the opportunity to meet and interact with your regional board member, discuss regional opportunities, challenges, and many of you took the opportunity to bring some questions and comments to the group, which Alex and Nadim will address in a little bit, and also allow you to engage with your colleagues from across the region and hopefully build professional connections that when you see each other next time or in person, you'll remember of having had made a connection.
Thank you, Mary. Indeed, this is a members' platform to talk about opportunities and challenges in gynecologic cancer care, highlight new initiatives, or tell you ways of getting involved and engaged in this amazing global community. Many of you have taken the time to submit questions. Thank you for doing this. And later on in this meeting, we will talk about these questions.
Thank you, Alex. So we'll start by looking at the IGCS as a global organization, and think it would be good to, at this time, to look about really how global we are. And if you can just look at this slide, IGCS is truly one of the strengths is this global presence. And if you can look at membership from this slide, for North America specifically, we have over 1,000 members. So thank you all for being members. And in addition, we have incredible alliances and the IGCS strategic partners for the region. And thank you, Shannon. And we are very grateful to our Canadian colleagues and the Society of Gynecologic Oncology of Canada. They've been long-standing strategic partners of IGCS and our amazing group of professionals. And as many of you know, we have so many colleagues in Canada. We're really honored to continue with this. IGCS really has experienced an exponential growth over the last 7 years or so because of this strategic partnership program and the efforts that Mary and the team has done. We have many, many colleagues from around the world who are part of the IGCS because of their regional societies. And again, I encourage any of you who are part of a regional society in North America to consider being a strategic partner with IGCS. And Mary can certainly provide some more details about that.
Thank you, Nadeem. It has been such a successful program. And as a board member, these past 2 years, it's so exciting to see all these groups wanting to join the IGCS. Just a few quick words about the IGCS annual meeting. In case you didn't know, the IGCS takes its meeting all over the world to high, middle, and low-income parts of the world. And we now have a process for regions of the world, many of our strategic alliance partners included, to submit a request to host the annual IGCS meetings in the future. You can see here the rotation and region of the world where the meeting is going, which is really exciting. You can see the trans-world movement of the meeting. Very exciting thing to look forward to. We're super excited about 2026 in Montreal, our North American destination. We hope to see many of you in attendance.
Yeah, Montreal is going to be a beautiful city. And the Canadian Society is such a great partner for us for the meeting. I just wanted to give a little bit of an update just on some of the newer offerings that we have before we move on. And then we'll obviously get to the questions and comments that were submitted. But I do want to talk a little bit about one of our newest ways to connect with each other, and that's to find a community of colleagues through our networks. These will be launching and we'll be piloting one in radiation oncology, one in medical oncology, and then 2 regional ones, one in Latin America and the other in Africa, Middle East. Soon, we will be doing a North American Connect network, and we will be reaching out for moderators. So hopefully people like yourselves who want to be interested will consider being a moderator of our network. Launch today is our new surgical film library with over 200 films reviewed by global experts from around the world on our learning portal, Education 360. So definitely check that out. I think it's a huge member benefit, and a big thank you to Ashley and the education team for working so hard on this. You know, we get a lot of questions about training, people wanting to do some other additional training. And so we're opening up an expanded training program that will launch early next year that will give people who don't necessarily need our fellowship program, but still want some type of additional surgical training. I think this expanded training is going to be a great thing for them, as well as launching a research committee. And that research committee, I think we'll talk about in a little bit, but I'm super excited that Alex has agreed to stick around and help to co-chair that research committee. So I think probably the other big thing is our early career network. And I don't know, Nadeem, you've been very involved and have vision of rolling out the structural changes for our early career network. Do you want to talk a little bit about that?
Yeah, sure. Thank you, Mary. So we've always had an effort in early career in IGCS, but this year you may have been reading about this restructuring of the IGCS Early Career Network. We recently sent the communication. So this was another great board discussion and strategic decision for IGCS. So we recently updated the members to include this central part of the new governance structure for the group. Is really the creation of an early career network executive committee. And next year, IGCS will have 3 new open positions for president, president-elect, and secretary-treasurer These are elected by their peers specific for IGCS Early Career Network. So the IGCS Early Career Network can nominate themselves through applications and for these three leadership positions, and will be open February 2026, so coming up very soon. And there'll be a lot more about this to come, so please stay tuned. This will also be something where only peers will be able to elect these three positions, so they will be voted by their own peers, not the entire IGCS membership. Importantly, this early career network, the president, this new position that we created that will be elected by their peers, will serve an ex officio on the IGCS board with voting ability. So this is a new position that we did not have before. There'll be an early career president on the board as a voting member, which I think is very, very important. So this is really a great opportunity for early career professionals to contribute directly to the global leadership of IGCS, ensure their voices are represented at the highest level of our society. Again, make sure they're aligned with our society strategy and mission. And I think it's very, very exciting. I'm really happy to talk to anyone more about this. And we won't, I see there are some individuals here who can meet this criteria. So I'm happy you logged in, and there'll be more coming. And if you attend or happen to be attending the Cape Town meeting in a few weeks, you'll see and hear a lot more about this for Early Career Network, and hopefully meet colleagues and start building this very exciting part of IGCS. Thank you.
Yes, thank you again, Nadim. Yes, it's been a very busy time in the early career area. I just wanted to conclude this portion of the meeting by encouraging many of you to give some thought to getting involved in the IGCS. We received a lot of questions about how to get more involved in the IGCS as a member. So I want to assure you that there are a lot of ways to contribute and make a difference, no matter where you are in your career, whether you're at the beginning, middle, or even a senior member of your subspecialty. You can, one, become a member or support colleagues in lower resource settings. Two, there is an upcoming expanded training program where you can become involved at any level of your career. And three, hosting observers at your institution, helping organize short surgical courses, or contributing to minimally invasive surgery training, which is not very common in a lot of regions of the world, and where we want to make sure that such programs become established. Or you can join virtual echo tumor boards and contribute to case discussions. You can also develop education contents within one of the IGCS education workshops and have opportunities to present such contents. You can also get involved in the IGCS amazing journal, the Journal of International Gynecologic Cancer Society. For anyone interested in engaging more with IGCS, just scan the QR code in the top right corner that you're seeing on this displayed slide. There is a lot of ways in which you can get involved. Thank you.
Excellent. So I think we come to the open forum on regional priorities and challenges, and we had so many great topics and comments submitted by all of you. And we can get started on our open discussion Q&A. So we took these comments and they fall into 4 buckets, basically about engagement and involvement opportunities. And we did mention some of these: international collaboration, and we can talk a lot about this, education, research, and science, and really development of standards and guidelines. So Alex and Mary, should we just open it up, or just continue to specifically address this through the comments?
Yeah, why don't we address some of the comments that were made in advance, and then absolutely we'll have plenty of time to open it up too.
Okay, so the 4 buckets that we created, the one that was very common was about engagement and involvement opportunities. And, we tried to cover this with Alex's comments on what's happening. And as far as the international collaboration, some of the questions were specific to the US impact of government shutdown, et cetera, which I think is very unique to some of us in North America, but not sure that IGCS really specifically is in a place to address this. And this is an evolving thing. We can certainly continue this conversation one-on-one through our organizations. As far as collaboration through our own societies and expanding efforts to North American society, we already have some really good collaborations. For example, with the Canadian group, we're working on collaborations and groups in Latin America. And I think we're also having discussions with our society in the US, for example, SGO. So this is ongoing and evolving. The third point was about education, research, and science. And again, we appreciate the comments. There were lots of comments, disease specific for ovarian cancer, trophoblastic disease, endometrium, cervix. And we do see that there is some concern about complexity of how things are evolving. And we're going through times with a lot of change. So we forwarded a lot of these comments to our education committee to better identify opportunities for education. And there may already be some things online with this content on our portal. To be honest with you, there's so much online. Many times I'm surprised when I hear that there's something, I go and find it. So the web is, the IGCS website is very, very extensive, and there's a lot of information that could be seen the more you look into the portal. Alex, do you want to say a few words about the research committee that we're launching and you're going to be co-chairing?
Absolutely, thank you. Yes, we're so excited about the growing interest in developing global collaborative research network within the IGCS, which, as you know, is a means to basically encourage more research participation from regions of the world where such has not been happening. The IGCS board recently approved the formation of a research committee, which will be formally announced at the Cape Town meeting. This is an important step forward for the IGCS as we continue to strengthen international collaboration and support meaningful ways to collect data. First focus will be on rare tumors. As you know, rare tumors are difficult to study because they're rare. And there can be a better place than the IGCS, which spreads across the globe, to collect data on such tumors. So there will be many ways for you to get involved. I don't know about you, Nadim, but the idea of having a global rare tumor registry sounds so exciting to me.
Yeah, absolutely. I agree with you. And again, I think it's a great initiative and will be multidisciplinary. So we're engaging a lot with our pathology colleagues and societies that specialize in GYN pathology. So this will be definitely multidisciplinary in nature and really allow us to capture data on these tough to treat conditions that are rare. We will learn a lot, and I'm grateful again that you are willing to co-chair and stay in this effort, Alex. We're also very grateful for the philanthropic support that we received financially with our World of Hope initiative to be able to fund such an activity, because again, starting such a registry and database, this is has to be a continuous effort and maintained and supported, and it's not an easy thing. So I think all of us will find this very exciting, and Mary and I and many others are working with our pathology colleagues. So you can imagine we can potentially do something with something like trophoblastic disease that could be global, that could be incredibly informative. Alex, I'll turn it back to you.
Yes, well, the pleasure is really mine. I have to tell you that since my first involvement with the IGCS, there has been no looking back, because the staff and all the people I've had an opportunity to interact with at the IGCS really make it easy to serve the IGCS as a volunteer. One of the key areas of interest for this meeting was the development of standards and national guidelines. And this came up in some of the questions that some of you posted as well, which we appreciate. We're exploring opportunities to strengthen our partnership with the NCCN to support both guideline development and adherence at the national and regional levels. And for those who do not know, our current Vice President, Professor Abu Rostum, is actually the head of the NCCN Gynecology Cancers Program. So we couldn't be in a better place to leverage that opportunity to help our colleagues all over the world. We hope this collaboration will help clinicians around the world with evidence-based recommendations that reflect global best practices in gynecology cancer care. Nadim, all of us know your involvement with the NCCN too, in case you want to say a couple of words about this.
Thanks, Alex. I think, we've always had this question, and it comes up in many societies. Should we have our own guidelines? And we've talked a lot about this, and we've thought a lot about this. And again, I don't want to speak for IGCS, but we've had these discussions, and we kind of felt that it's such a incredibly important and exhaustive effort, and IGCS can spend the effort and the resources and the money in areas other than having our own guidelines. So that's why I think teaming up with professional organizations that do this well would be probably a better effort for us. But again, I'm not speaking for the almost 10,000 members of IGCS, but I personally think when you have organizations that all they do is just guidelines, and they do guidelines for every cancer on the face of the earth, and not only for cancer, but for chemotherapy and complications and quality of life and survivorship. It's much better for us to team up with those and align. And I think what we're trying to do, which is beautiful, is to be able to provide much more input on these guidelines specific to GYN, instead of like creating our own IGCS guidelines, which I think will be redundant and an incredibly expensive and time-consuming effort. I think we can be smart about this and align and influence and be part of it than to really own it completely. So, but that's my personal view.
Yeah, and Nadim, remember we're piloting with the Philippines.
That's exactly right. So what Mary is saying, some of you may know, the NCCN has region-specific guidelines. So we have Sub-Saharan Africa specific guidelines where we actually go and meet. We have 12 countries that provide their own guidelines. So these are things that I think are very much worthwhile, because guidelines in Sub-Saharan Africa may be a little bit different from North America or Canadian guidelines. Or we're trying to do the same now in the Philippines. Shannon, go ahead, please.
Yeah, I agree with you. I think it's too difficult, especially because you're also not just dealing with, okay, what's best practice, but what is also approved and available in individual countries. And that becomes too much of a challenge when you're looking at the differences, even between Canada and the US, even though incredibly similar on everything, the actual approvals of medications are very different, because that's not necessarily controlled by us. It's controlled by industry sometimes. And so what might be available in the United States, not available here, not available in other countries, because they haven't made the efforts to go through the regulatory bodies. So I don't know if, I don't foresee kind of global guidelines as being a best use of resources, when it's more of advocacy for equity of care. I think that's where the better bang for the buck sits.
Thank you so much. Couldn't have said it better. And really, thank you for supporting this, because we kind of felt the same way as you said. And it's much more complex. As you know, every 6 months, things are changing. So it's a dynamic process. Gone are the day where you can actually print guidelines and use them for 3 or 4 years. Everybody knows that every 6 months. So that's why the NCCN is a dynamic process. We say never print the NCCN, always go to the web, because the web is the freshest and newest. And if you have NCCN guidelines from 2 years ago, they're already obsolete. So especially on the chemotherapy tables and the adjuvant therapy table. So thank you for saying that. I think we have time for questions now, right, Mary and Alex? Should we?
Yeah, we do. I actually want to put Shelley on the spot. I know you put in the chat that you're radiation oncology. We like to brag, if you will, at IGCS about being multidisciplinary in nature. And I want you to be honest. And we're doing our first contouring course, which will be of many to come and years to come. And as Nadim mentioned, we have a really nice partnership with the International GYN Pathology Group, and we're building our radiation connections as well, and hope to soon announce something with the American Brachy Society. But I'd like your input, Shelley, or your perception of, as a radiation oncologist and, you know, knowing IGCS, do you feel like we're getting there? Do you feel like we're multidisciplinary? Is it a lot of lip service? You can be honest.
No, I actually, I'm not going this year, but last year I did attend the conference and I did feel it very actually encouraging and nice to be sitting there in that conference and having a true multidisciplinary feedback. Because generally when I attend ESTRO or some radiation oncology conference, there it's very radiation heavy. And you always feel like, I wish the surgeons were sitting there. I wish the, you know, because in US, surgeons are the ones who are giving chemo as well, but you need to hear them. So I truly feel that was the main crux, the experience that I got during the last conference, actually. So I do feel that, yes, IGCS is a multidisciplinary team, and that's why I'm part of it, because I want to hear from all the sides, because no cancer I am treating on my own. Right. So why would I not hear the voice of my colleagues to make my patients' care more valuable and more, I would say, intelligent, with all the intelligent brains fitting in. So I really appreciate the effort and contouring. And more than that, if I may add, I feel radiation oncology per se works in a cocoon. So as to say, people outside the radiation oncology discipline generally have, I would say, just because we do not have that level of interdisciplinary communication, um, that much of understanding of the techniques that have changed and how we can kind of, expand the use of that this non-invasive modality. For example, my research interests are oligometastatic disease, right? And I feel like that is one space in gynecological oncology, which is like right now is understudied as compared to other cancers like prostate or lung and whatnot, where we can expand as a team, the efforts. So in my head, the goal is to treat our patients with a combination of the modality, whatever works best for the patient, and not like my modality is better than yours or yours is better than mine, if that makes sense. So yes, I do feel, and I think that's the reason why I'm here today, because I'm really interested in expanding that phase of our gynecological cancers. So it is there, and there are another question that actually you guys discussed at length about guidelines and all. I was also one of those person who has left that question, but my goal was not to kind of change what NCCN is saying, but to kind of complement that. For example, I'll just give you one example. In young patients, when we treat cervical cancer, many a times we are doing ovarian transposition in those patients, right? With my colleagues, the discussion that I get is now is what kind of radiation fields am I using? How far my radiation is going to go, and where you should implant the ovaries, so that after implantation, we are able to protect that. So I would say that was a missing link somewhere, and I went everywhere to figure out if there are certain guidelines somewhere, because in just few years back, we were treating these cervical cancers with 3D techniques, right? You put the blocks, you have anterior field, posterior field, and the side field. This was easy. Now we are living in an IMRT world. So this cross communication is very important. Surgical techniques are changing, radiation techniques are changing. Radiation profile in the patient is changing. So if we are transposing those ovaries, we should be able to protect that. But how are we going to protect? Only if we are communicating and telling our surgeons that where to implant it, so that even the scatter radiation dose doesn't go there. So that's how I had been thinking about these guidelines, not to come up with our own guidelines, but there are certain areas where NCCN can just go so far, right? There are patient specific things that we all can kind of dwell in a little bit deeper and kind of complement those guidelines. So that's what I was thinking about the guidelines.
Thank you so much. If I may respond, I think completely everything that you said, I completely agree. But again, not to advocate for NCCN, but the specific comments that you said regarding, for example, ovarian transposition and fields, you can very easily, if you have the time, you or any of your colleagues, you can put together a statement, recommendations, and the NCCN has a very easy way online to submit these. They get reviewed, and then things can change. So that's what a lot of people do. So anytime you have a suggestion, the Radiation Oncology Committee on the NCCN is very open to these, and please feel free to do that. And if you have any changes. And also, I think as IGCS, if we see something that I think is important, we can certainly put it in writing and send it from IGCS to NCCN. So if you have a proposal that you think we can present it through IGCS, and then IGCS can send it to NCCN if you prefer.
Thank you, Nadim. If I may just chime in quickly, not that I have anything in addition to what you've said, but the initial part of your comment is what I want to reinforce, that, you know, creating a guideline, I belong to quite a few of guideline committees, including ASCO and ACOG and all that, is labor intense and financially very, very, you know, impactful. And so I agree completely with Professor Aburostum that creating guidelines cannot be a labor-wise venture for the IGCS. But that doesn't stop us from creating, you know, a clever way of helping our members to navigate the available guidelines. NCCN obviously will be top of those guidelines, but there are many guidelines of different societies that are available for public utility or utilization, and we can leverage that advantage and make them available through the IGCS website. For instance, the comment that you made about these ovarian transposition, I actually think that part of ASTRO guideline addressed that specific question. How detailed that is, you're going to have to go there and see it. But I think it's something that society has addressed. We can always pull those into the IGCS educational material, you know, archive for people to have access to.
And just to add one more comment, just to show more engagement. So I think through a lot of effort with the IGCS leadership, we were able to engage more and more with FIGO, a society that's been almost impossible to break through. And FIGO is now has a completely different standard operating procedure. And this year, just a few months ago, the new FIGO staging system for trophoblast disease was circulated. IGCS received a preliminary version of the staging system. IGCS with Professor Greta Dreyer formed a committee. They reviewed the guideline, they reviewed the new proposal of the staging system, sent back comments to FIGO. So this is wonderful for us because we never were able to, this is the first time through engagement with FIGO, we were able to do this. And hopefully this will be our standard moving forward, that anytime an organization like FIGO is going to change cervix or endometrium or ovary guidelines, a group like IGCS should have an input. So,
yeah, I totally agree. Kathleen, you know I'm going to call on you. Kathleen has been a long-standing, well, yeah, years and years of volunteer leadership at IGCS. So, any advice on that, Kathleen? Anything you'd like to add?
Sure. Hi, everyone. It's a little bit loud where I am, so I apologize. Great to see everyone. I'm a GYN oncologist at MD Anderson, and great to see Shelley, my neighbor. I don't think I sort of agree with a lot of what's been said about we shouldn't redo guidelines. I think we should leave that to the people who do it really well, like NCCN, and if anything, help support their efforts more than we already do. Which Nadim can help all of us participate more in. The other thing I just wanted to bring up was just another new initiative from the IGCS, which is really participating and drilling down on the cervical cancer elimination initiative. And I think myself and many on the call do a lot of work in other countries, since we have the good fortune to come from North America and have very good cervical cancer prevention systems in place. But what I'll also say is with the meeting coming up in Montreal, I think it'll be a great opportunity for us to look at some of the disparities we see in our own countries, and especially in the US. And there are a few states, ours included in Texas, that have developed a cervical cancer elimination because we have such high rates in some areas. So just something else for people to get involved in and for us to think about, as we'll be having the same sort of symposium attached to the meeting in Montreal next year.
Yeah, so Kathleen's referring to, and I apologize, we didn't include it in here, Kathleen, but it's the IGCS's commitment the next 5 years, so till 2030, which has kind of been the date set by WHO in terms of their elimination strategy, to have this kind of forum to address where the meeting's located, the issue of cervical cancer elimination. And so obviously doing one in commencing in Cape Town, then we'll go to Montreal, on to Asia, and then Latin America. So each region of the world brings a little bit of a different challenge and a lot for us to learn from as well. And so I'm super excited for the one in Africa. But also, as Kathleen mentioned, when we get to Montreal, learning about Canada, the US, and the pockets of where there isn't, an equity of care, right? So yeah, it's a big commitment on the part of IGCS. I really am thrilled that the board has, approved this and will move forward. It's just so in our wheelhouse. So it's really great. Shannon?
Yeah, actually, the timing of this is fantastic because I don't know if you guys saw it, the cervix cancer rate in Canada is the fastest increasing cancer right now. I know, and it's terribly embarrassing for the country, and a lot of it has to do with lack of access to screening in our remote locations, and now the dropping access to primary care physicians and everything. So we are quite literally just about to put out the white paper that's supported by all of our national organizations here in Canada who are in this wheelhouse. It's going to be published in Current Oncology, and I just submitted the final manuscript today with all the revisions, so I anticipate hopefully it's going to be up by the weekend. But this is definitely something that when we come to Montreal, we can really highlight the areas that we have really fallen through. It's been a very unfortunate situation. It's our marginalized populations, our distant populations, because of course Canada has a huge issue with extremely remote communities with no access at all during large portions of the year when the weather's poor to even be able to reach a center. So there's a huge push for self-screening to be able to try and get self-collection swabs that are stable within, very poor weather conditions, down to -50 up to +40, so that we can start doing transports around the country. But I agree with Kathleen how important it is to move forward with this, because it's such a solvable problem. Across the whole world, it's a solvable problem.
Yeah, it's very sad to hear this. I mean, and we have resources, but everything you outlined is so true. And hopefully at the meeting in Canada, this could be a huge, huge effort to try to really bring it out to the media, to people, politicians, whoever can influence this. It's just unbelievable how this is happening. And like, we have the tools. All we need is one dose of vaccine and one screen, and we can really make such a huge, and same thing happened in Japan a few years ago. I mean, unbelievable, like the countries with resources, with talent, with education, and we have a vaccine that can help incredibly. It's just so sad. But maybe next year's meeting should really focus a lot on this, Shannon.
Exactly what I was going to say. Nadim, you took the word out of my mouth. I think the Montreal meeting, we should marry whoever the committee, educational scientific program committee leader would be, needs to get the message that is being discussed on this platform right now, that we would want a dedicated section to cervical cancer prevention. That is just going to be so important. I can assure you that the problem that you're facing in Canada is obviously not unique at all to Canada. What Nadim said is what is making it really disturbing, because considering that this is a country that is well developed with all the resources that it has, I mean, but then Japan had the same problems. I can tell you this, when I was in medical school in Nigeria, I remember they call this floor, they call it the fourth floor admitting, you know what? It had more than 60 beds, that floor. Now, I practice in a large region in the United States, in Western Pennsylvania, where the largest center, we see roughly about 40 new cervical cancer cases every year. In that unit in Nigeria, the 60 beds were constantly close to 100% full. I mean, that's how bad it was. So the government of that country, and I am going to be linking Mary up with the task force, has formed a task force, and they are massively making moves and pouring money into boosting screening and obviously making vaccination more widely available. What is curious to me, though, is how in the United States, my own country, how the uptake of vaccination, it's kind of all over the map, depending on which region of the country you look at. It's as low as 30% in some American regions. And yet we have the example of Australia and the massive success that has been achieved there. And nobody is wanting to cite that to emulate why we should be doing things differently. It's really sad.
And Rwanda. So if you can do it in Rwanda, you can do it. And all it took is leadership. They had good leadership in Rwanda.
Yeah.
Got the problems in all the, right, Alex? I mean, they had a great minister of health and she got it done, you know?
Yeah, the North American is going to present obviously similar and different challenges, but also could definitely, require policy discussions and bringing, the higher level decision makers to this, because some of that is, what's needed. I do like this discussion on elimination, and we tend to focus on treatment at the meeting, right? But I like that, Alex, that extra flair of elimination. So I think it'll be great. I'm super excited to kick this off in Cape Town. And, I think my biggest fear, Kathleen knows this, we've talked a lot, is that we just up and all of a sudden leave Africa, right? And we can't forget them, because there's a lot of work to be done. And so we have to think about the sustainability of what we're building when we're there, and who are the right people to continue it for us. And then ultimately with our, continued involvement too. So yeah, it's super exciting.
And I think also from the North America standpoint, we have some great, Al Evans and Barry Rosen will be winning an award, have done unbelievable work in Kenya for 20 years probably, and lots of others. Like, if we can also work to engage more and really bring together that global community. And Shannon, to your point, we can probably learn a lot from our colleagues in Africa as we start to have all these problems in the US. Yeah, Shelley and I were taking care of at least one advanced cervix cancer patient in Houston every week, despite the public hospital being a few miles from both Baylor and MD Anderson, right? So
yeah, it's there. And I think, the discussion on cancer control plans, treatment plans, things like that. There are some states that are starting to come around. I know Texas, Florida, I think Alabama. So we want to hear from those people who have been instrumental in developing those plans. So yeah, definitely. Is there anything else anyone wants to bring up? Any other comments? It's been great.
Mary, just a couple of thoughts, going back to Alex and Nadeem, what you were talking about related to the rare tumor registry. So, just a couple of thoughts or questions to perhaps think about, and we can talk about it another time as well. In a lot of ways, the treatment algorithms or dissemination are only as good as the diagnosis. And even in the US, there's actually NIH studies shows that misdiagnosis for rare tumors can be as high as 40%. And internationally, I imagine that number is going to be, fairly substantial. And in this day and age, where you can do digital pathology or, and you can do it at not a incredibly expensive rate at all. I think, because I think about that a lot in the context of international systems and so on. And I just wonder that, as you think about like the rare tumor effort, just two thoughts around that. One is to how to enhance or improve diagnosis, because the treatment algorithms are only going to be as good, unless we get the diagnosis right. And then along those lines, with regard to the registry, there are a number of sort of international efforts or registries that are existing, and I wonder that to a certain extent whether IGCS could help serve as a whatever that model may look like, either as a hub or as a way to sort of organize some of these broader efforts, not to duplicate, but perhaps to work with them or enhance those or whatnot. That I know will take more than the 10 minutes or so we have left, but I just thought I'd mention just a couple of thoughts.
I think they're both amazing, Anil, and I agree with you. And Mary knows, and she's been really helping a lot. There's a society, the International Society of Gynecologic Pathology. It's one of our strategic alliances. They have almost 800 members. These are GYN pathologists and
right.
And we've specifically, Mary and I have worked with them a lot this last year to try to engage them. And specifically, one of the asks was difficult case virtual tumor board, like you were exactly, Neil. And it turns out that ISCHIP has such a forum for their own pathologists. And one of the things that we're working on to see is how we can engage and link to that. So we are working down that path to see how we can do, a once a month difficult or challenging case that would be purely pathology based. But of course, GYN can also log in and learn and educate. And as far as the registry, I think your suggestions are very, very good. I mean, there are registries out there, and as this research committee forms with Alex and others, they can hopefully look into that and see how we don't need to reinvent the wheel, but maybe we can tag on and supplement. So I think there'll be a lot of work for this newly formed research group. But your question about the diagnosis is very, very valid. And we need to team up with pathology, and we are. But pathology, it takes a while. Mary knows that. So we're making progress with this chip, I think.
Yeah. And I think to your point, Anil, about existing registries out there, we had a call with ISSTD. And I know there's an Australian initiative. I think even MD Anderson at one point was looking at. So I think we got to coalesce and bring everything together. If everybody knows the top 15 data points to collect, amazing, right? We can spread this on and pass it along. I certainly do not want to reinvent the wheel in any way. And then also looking at the potential of using, RedCap or something that's free, for colleagues across the globe that have a hard time accessing systems and things like that. So we may have found your board project here, Anil.
So I think that's a good one.
You bought it, Anil. And honestly speaking, I agree with both Nadim and Mary, and your points are solid. I want to give credit to some of our College of American Pathologists members outside of the ISGIP mechanism or organization. Some of the pathologists have been working independently with IGCS for quite a few years, and Mary can allude to that. They participate in some of the ECHO programs that we have all over the world. They are present at the tumor boards. They help the pathologists in these under-resourced regions of the world to secondly review pathology slides by digital means. And some of them are even willing to fund transfer of slides and do special statements for them. So I think when it comes to curating that tumor board, when we make it happen, which I agree with you completely, we don't want garbage in, garbage out. We would be able to leverage all of these already existing collaboration between us and the pathology group to make sure that if we ever, go the distance, it will be a very worthwhile tumor registry to create. Of course, in collaboration with anybody who is already working in that area.
Yeah, definitely a great opportunity for people to be involved who have an interest, in this. Absolutely. Jennifer, thank you for joining.
Hi, everyone. Sorry I was late. I'm one of the first year research fellows at UCI, so I had a loud meeting. Sorry I joined late.
Thanks for joining. That's awesome. Great. Good. Anything else for the good of the group? Anything anyone wants to share? I really appreciate it. I know it's a busy time of the day for everyone in North America winding down. So we'll follow up and we'll get the recording out and everyone can kind of listen at their own pace and time. Anything from my team? Anyone want to add anything?
Eric.
Hi, hello everybody.
Early
Who's a social media champion? Hi, Eric.
Oh, Eric, our social media champion.
Yes, past social media champion. So nice to see everybody. This is an incredible experience that is being launched here today. Unfortunately, I won't be in Cape Town, but I did register to join virtually. So looking forward to catching all the recordings afterwards. I just wanted to give a quick comment about the surgical film library that was launched today. I was very excited to see that in my email this morning. And I think that's a really great opportunity for the whole membership in general, but also for fellowships, for fellows, and I'm graduating, it's my last year in fellowship now, and really keying in on surgical video has been one of my main focuses here during fellowship. And I'm really curious about, and I haven't had a chance to log in yet and look at it, but I'm curious if those videos are videos that were submitted to past annual meetings or if they were specifically tailored for this surgical library and what the process would look like for submission in the future.
Yeah, I can talk about that if that's okay.
Sure.
Okay. I'm Ashley Jones. I'm the Senior Manager of Education and Marketing for IGCS, Eric. And they did come from past annual meetings, so New York, Seoul, Dublin, and then we'll add Cape Town after the 90 days on demand comes up. We also got films from IGGC video articles, along with past surgical film festivals that I think began in like 2020. We got all of those films. We also have films from our MIS fellowship program. So you'll see ones from like Mario Lateo and Vance Broche. Shout out MSK for Dr. Abu Rustum there. But yeah, we also opened up a submission process over the summer, and we asked our members to submit films to be included at the launch. And from those submissions, I think we had close to like 50 from the submissions that were accepted, which led us to over 200 films launched today. I'm very excited about this. It's been a long project for me that Mary has heard ad nauseum probably. But along with that, we will be taking new films beginning next year. I'm trying to give our surgical education work group a little bit of a break, a well-deserved break in the next 2 months. But yeah, be on the lookout for new films starting in January and submit your own films.
Yeah, and the Japanese actually submitted some as well. So it's great to have an international scope and look at different ways that people are, conducting surgery. So yeah, it's very cool.
Yeah. I also recorded a functionality video. So you said you haven't logged in yet. When you do log in, it may seem overwhelming because there's a lot of like options. It's 200 films to get through. So you can watch that functionality video and kind of get a little tutorial to get you started. But it has bells and whistles, that's for sure.
That's awesome. Congratulations to the team for launching that, and thanks for that info.
Yeah.
Great. Good. Well, we're almost to the top of the hour. Alex, Nadeem, anything else you want to add or close out for us?
Well, thank you all for your active participation and valuable contributions throughout today's session. Your questions and comments truly made the discussion meaningful. We will take into consideration all of it and make sure that we work towards supporting your needs. Again, thank you so much.
Thank you, Alex. Thanks for all your help, and thanks, Mary and the group. And really looking forward to working with Anil and the rest of the team. And please remember the Early Career Network. So spread the word to your colleagues, to your fellows, to your residents. We want anybody who's young and who's within 5 years of graduation to try to join. We want to have a robust voting and membership and representation. So I think this would be huge for our society to have this. So thank you so much.
Great. Well, thank you everyone again for joining. Have a good rest of the day and the week. And I hope we all see you soon. Thanks again.
Bye-bye.